procedure that is staple hemorrhoidopexy. Mechanism is excises it excises circumferentially ring of rectal mucosa above hemorrhoids, and it repositions the hemorrhoid upwards, reduces the blood flow but does not remove the tissue. Advantage is less pain than the other surgical procedures and faster recovery than excision. Disadvantage is it has higher recurrence rate and risk of rectal perforation or sepsis. Not ideal for large external components.
Hmm.
Another newer technique is the Doppler guided hemorrhoidal artery ligation mechanisms. Doppler probe identifies the hemorrhoidal arteries, surgeon ligates them. It is indicated in the grade 2 and grade 3. It can be combined with the leukoplexy or prolapse. Its advantage is low pain, is there rapid recovery and tissue preservation, and disadvantage is higher recurrence than the excisional surgeries. Post-operative care is the video educate analgesics to the patient. We advise the patient for high fiber diet, stool softener to avoid straining. We advise the patient for stage 6 bar and monitor complications like bleeding, urinary retention, infection, and we follow for as we follow to assess the wound healing. Thank you so much.
अभी इसे दिखा अब दिखा सब को ये क्या दिखा रहा है ये तो चैन है
The last speaker for today's seminar is Dr. and he will be discussing ODS and SRE writing.
Sales like this. No, no, board sales. Sales is like what time? Board.
Esteemed consultants, respected senior residents, Assalamu alaikum. And Dr. Suhail Abbas, I will be throwing some light over ODS and SRUS. As we all know, chronic constipation is a very common problem that affects around 2 to 3% of the people in the Western world. And a significant proportion of this is because of ODS, obstructive defecation syndrome, around 30 to 50%. In obstructive defecation syndrome, feces do reach the rectum, but rectal emptying is extremely difficult. These patients have a feeling that defecation is blocked, despite repetitive attempts. Complete evacuation of rectal contents is not possible. Patients may also complain of prolonged or unsuccessful straining at stools, feeling of incomplete evacuation, digital removal of feces, and laxative abuse. Constipation caused by obstructive defecation is of two basic types, functional and mechanical. In functional, the cause of idiopathic megarectum, rectum is more than 6 centimeters at the level of the brain, and small in which there is pelvic floor dysenergy, descending perineal syndrome, in which the perineal descends more than 3 centimeters at the level of the perineal body, and then mechanical or rectocele, enterocele, internal intersusception, and or rectal prolapse. All of these conditions represent either a defect of pelvic support or abnormal function of the pelvic floor musculature. Diagnosis of constipation, there are around 3 guidelines for a patient to be labeled as suffering from functional constipation, which also includes ODS. Following criteria should be present for at least 3 months. First is it must include 2 or more of the following: straining during defecation for at least 25% of the defecations, lumpy hot stools for at least 25% of the defecations, sensation of incomplete evacuation for at least 25% of the defecation, sensation of anorectal obstruction or blockage for at least 25% of the defecations, manuals to facilitate at least 25% of the defecations, for example, digital evacuation or support of the pelvic floor, fewer than 3 defecations per week. Of these 6, there should be at least 2 or more, and their second point is loose stools are rarely present without the use of laxatives and insufficient criteria for IBS. There is pain abdomen which is relieved by defecation. On physical examination, paradoxical contraction of pelvic floor can be assessed by palpation of the puborectalis muscle while the patient is straining. Perineal descent greater than 3 centimeters or mucous discharge or mucosal prolapse may also be seen when the patient is asked to strain for stools. However, most clinicians do not rely on palpation and advocate the use of specific tests for ODS like EMG, BET, and radiological images, which I'll explain it a bit further. In EMG, electromyography, activity of the pelvic floor is measured with a needle or wire electrode inserted in the puborectalis muscle with the patient in the left lateral cushion. In pelvic dysenergy, EMG shows a paradoxical increase in activity of the puborectalis muscle during straining. In balloon expulsion test, balloon is happening in the rectum, and it is expelled. It is collected water or air around 60 ml, and patient is asked to expel the balloon. Normal subject should be able to do in up to 1 to 5 minutes, but inability to expel the balloon supposes the diagnosis of obstructive defecation syndrome. Difficography, here patient we put the barium sulfate around 60 ml. We put it in the rectum radiologically, and patient is asked to evacuate the barium sulfate. On difficography, ODS is characterized by lack of widening of the anorectal angle during attempted evacuation of contrast. In normal individual, during strain, the anorectal angle becomes more obtuse because of relaxation of the puborectalis muscle. Difficography is reported to be too sensitive and can lead to false positive diagnosis. Now we have added magnetic resonance to conventional difficography, which is more dynamic, good temporal resolution, and high resolution of soft tissue contrast, which makes it an ideal modality for assessing of the ODS patients. Then there is another investigation which we can use, that is ultrasound, dynamic transperineal ultrasound. Because of this widespread spread availability and low cost, it is recommended as a first step analysis for patients present with ODS and a marker for more selective use of dynamic MR imaging. In other advantages include lack of radiation exposure, repeatability, and its ability to define the presence of intrinsic and extrinsic anal control anomalies. Then anal manometry is another investigation, which is thin plastic catheter is placed in anus and rectum to measure the sphincter muscle pressure. Normal pattern is characterized by increased intrarectal pressure associated with relaxation of the anal sphincter. Is characterized by adequate propulsive forces, intrarectal pressure more than 45 mmHg and increased anal pressure. Type 2 pattern is characterized by inadequate propulsion, intrarectal pressure less than 45 mmHg and insufficient relaxation or a contraction of the anal sphincter. Type 3 is characterized by increased intrarectal pressure more than 45 mmHg with absent or insufficient relaxation of the anal sphincter pressure. Both type and 3 are classified as dysenergic defecation. Colonic transit study is another which we can use for diagnosis, in which capsules containing 24 radioaopaque markers are ingested and abdominal radiograph is obtained after 5 to 7 days. Left side with all rectal population such as ODS, whereas the right one is colon restriction such as colon connection. Treatment. Many forms of treatment have been proposed with varying results, including dietary modification, laxatives and enemas, biofeedback therapy, electrostimulation, cerebral neurostimulation, and surgical intervention. Biofeedback is the first line therapy to manage the pelvic floor dysenergy. Most important thing in biofeedback is to make patient aware of his defecation process, asking patient not to force explain defecation after initial motion has passed, despite feeling of incomplete evacuation, arrests the progression of functional ODS or prolapse. Biofeedback training attempts to coordinate pelvic floor muscle relaxation with active contraction of abdominal wall musculature, generating a downward propulsive force. Patients who do not respond well to course of dietary management and biofeedback should be considered for injection of botulinum toxin into the puborectalis muscle and external anal sphincter. In this study, it was reported that 75% of the patients improved, although the benefit is short-term, ranging from 1 to 3 months in most patients. Most significant side effect is transient fecal incontinence, which occurs in up to 25% of the patients. The major disadvantage with the use of botulinum toxin or it is cost and short duration of benefit. Surgical return of puborectalis muscle in the posterior midline is reserved for patients with intractable pelvic dysenergy who are debilitated by their symptoms. However, the results of this procedure are not encouraging. If ODS is associated with any other structural anomalies like prolapse, rectus, it merits surgical intervention. Stable rectal resection is a new surgical procedure that was introduced for such morphological anomaly. Longo proposed the use of two circular staplers. The first to reduce the anterior wall defect, and second to correct the intersection posteriorly. Data from European STAR registry reveals a significant reduction in ODS scores coupled with the improved quality of life. Then modified longo score is most commonly used scoring system to decide the treatment strategy for ODS patient as well as to see percent and total change in ODS symptom after baseline from baseline after intervention in short term and long term intervals. The modified longo score in which we have 8 questions, and for 1 to 6 we give score. Each point is scored according to the frequency of the symptom. 1 to 6, we give 0 if there is no symptom. 1 score is given occurs once weekly. 2 if 1 to 6 times weekly, and 3 if it is every day. And question 7 and 8, no alteration of the lifestyle. Question 7 is if time will be divided. 0 is score if less than 5 minutes. 1 is if 6 to 10 minutes. 2 if it's 11 to 20 minutes, and 3 is given score when it is more than 20 minutes. Then score 8 it has also 0 to 3 pointers, and 0 is if there is no alteration in lifestyle. 1 is mild alteration, 2 is moderate, and 3 is if there is significant alteration in lifestyle. Some hospitals have taken 9 as cutoff for surgical intervention that STAR in ODS patient, while others have taken 7 as cutoff. There is no consensus till date on the cutoff score. Conclusion is that ODS is a problem that is frequently encountered in elderly females, and management should be tailored made to each clinical scenario. In elderly females, because of NVD, which causes the extension of the pelvic floor muscles and nerve injury. Then there is solitary rectal ulcer syndrome. SRLS is a real chronic benign disorder characterized by combination of symptoms, clinical findings, and histological anomalies. 20% have single ulcer, while 40% have multiple ulcers, and remainder have non-specific such as hyperemic mucosa or pseudopolypus. Is a disorder slight female predominant. Cause multifactorial tuberculosis, these two conditions result in trauma.